This is Audible Bleeding, the Vascular Surgery Podcast. We're here to help you keep your finger on the pulse.
Welcome to the third episode of Audible Bleeding. We are very excited to have Dr. Malachi Sheahan as our guest today. Mal is a professor of surgery and the Claude C. Craighead Jr. Chair of the Division of Vascular and Endovascular Surgery at the Louisiana State University School of Medicine in New Orleans. He's also the program director there for the Vascular Surgery Integrated Residency and Fellowship. He is the current medical editor of Vascular Specialist, the official publication for the Society of Vascular Surgery, and he's a member of the Executive Council for the Association of Program Directors in Vascular Surgery, co-chair of the SVS Wellness Task Force, and a member of the Fundamentals of Vascular Surgery Task Force. Just a few words about his training. He completed his general surgery residency at St. Vincent's Hospital and Medical Center, New York. He had a 2-year clinical research fellowship in cardiovascular and thoracic surgery at the New England Medical Center, and he did his vascular surgery fellowship at the Beth Israel Deaconess, during which time he found time to get married to Dr. Claudia MacArthur, who happens to be one of my co-residents and my very first fellow when I was an attendant. He was on staff at St. Vincent's for a year, and then he was recruited along with his lovely wife to join Dr. Larry Hollier at the LSU School of Medicine, and the rest, as they say, is history. Mal has specifically asked me to say that anything he says today is his own opinion and does not necessarily reflect those of the organizations to which he belongs. Thanks, Mal, for agreeing to talk with us. We're really excited about this.
My pleasure.
So, we like to talk about sort of what geared you to become interested in the career of vascular surgery. So what were the sort of things that attracted you to the field at the beginning?
Probably like a lot of current vascular surgeons, it was a long, pretty convoluted path. You know, I'm obviously a 5+2 because I'm old. So we came through general surgery. And I fell in love with trauma and then transplant. And then, as you noted, I did 2 years of cardiothoracic. In the end, this was all in the late 90s. And, you know, the writing was on the wall as far as endovascular. That was clearly going to be the future. And I just felt that vascular surgery kind of encapsulated that the best and was probably the best position for future careers.
You know, I think we have some overlap in terms of mentors. You know, I did residency with Dr. Hollier at the Sinai, and then he ended up on LSU. Can you talk about some of the mentors that interested you in vascular, like what characteristics they share and what made each one of them unique?
You know, you mentioned my wife, Claudia, and she and I actually went to medical school together, although we didn't really know each other. We were a year apart. As she likes to say, I'm much older than she is. But we had the same mentor in medical school, and that was Jim Menzoian. And he was just a great guy. And people do a lot of scientific studies about what makes a good mentor. But the bottom line is, you know, they're affable and they show an interest in you. You know, as a medical student, you really feel like a nobody most of the time. And so for the chief of vascular surgery to kind of show an interest in you was a big boon, I think, for both of us. And so he planted the seeds. And even though we both went to general surgery, I think that was always there in the back of our heads. And then, you know, when we kind of found our way back to vascular surgery. And then Larry, you know, Hollier is a much different mentor. He was with me at the beginning of my career. And he's just a great role model, always very positive. And, you know, he and I went through Katrina together. And after that, looking at kind of a devastated landscape, he was always upbeat every single day about what potential we had and what a great thing this was going to be someday. And he was right. It took, you know, probably 3 times as long as he promised me, but he was just kind of having that upbeat attitude. And, you know, even at basically the end of the world, that we will rise from this was such a great role model. And Robert Batson, who's our current chair of surgery, was there with us as well. And also forming such a strong structure for Claudia and I to come in and really restart the vascular program in New Orleans.
It's funny you mentioned Dr. Hollier's positivity. I think I remember as a fellow, I was walking in at 5 a.m. pre-round, and he was walking out, and he had come out of a redo thoracoabdominal and some with an infected graft and MRSA infection, and he had this big smile on his face, and he was like, "It was a great case, great case." I think he may be the only person in the world who would characterize that as a great case, but that's exactly one of his strengths, was his positivity.
Yeah, we have a competition among the trainees to see who can present a case in our conference that's horrible enough that he won't say great case, but 15 years in running and no one has taken that crown yet, so there's no bad cases to him.
That is very funny.
Hi, this is Adam, and as a rising fellow in vascular surgery, I just wanted to ask, you know, as an educator, what you look for in your trainees for vascular surgery, and what you look for kind of in mentees, as you know, you are now in more of a mentorship role.
Sure. Here's where we can get a little politically incorrect, I guess. But I say this to everybody I interview, essentially, is that you can't fix lazy or stupid. Those are the two characteristics that I've never been able to fix. So I look for people who are smart and motivated. And then, I don't worry about things like technical ability or even research prowess, because all these things can be taught. So, medical students get very bent out of shape, especially applying an integrated program, what their CV looks like. But those two things are critical. Now, if you're motivated, if you're hardworking, and if you're, reasonably intelligent, which hopefully everybody is who's applying, then you can be made into a great vascular surgeon, in my opinion. And I think that's really all it takes. If you're not that motivated and, you're not that into it, it's very, very difficult. I don't think we're really here to inspire people. We're here to hone them and train them.
Hi, Dr. Sheahan. This is Nicole. I wanted to go back to the path that you took to vascular surgery, because it sounds like you made some critical decisions along the way that sort of took you in the end to vascular. And I wanted to know if you felt like you took some risks along the way that made you successful.
There are things we see as risky that in retrospect probably were not that risky. Taking time off of a residency to do 2 years of research seems like a risk. Am I going to lose my technical skills? These people who are my junior residents, they're now going to be my senior residents when I get back. This is 2 more years of my life without, a decent salary. My loans are building up. What's going to happen with all of this? But I really look at, the years I spent in the lab, both at Tufts and at Harvard, as some of the best years of my life. I think it made me much more well-rounded, even though the types of research I was doing there are not necessarily the types I'm doing now. It teaches you a lot of things, how to interact with people, how to be successful. When I did general surgery, it was kind of seen as a risk to leave. There's still parametal programs, and you could be replaced at any time. It's not the same now, obviously, that people worry too much about where they'll fit in or what other people think of them, rather than trying to build themselves to be successful and well-rounded.
Dr. Sheahan, this is Matt. What about after your training? Decisions you made, either successes or failures, that kind of led you towards, being the division chief or your involvement in the SDS?
A lot of it is perseverance. If you're going to enter academics, I think that you should maybe not mimic people who preceded you. I think it's hard to take a career and say, I'm going to be Frank Beast, I'm going to be Larry Hollier. I think that's kind of a foolhardy process. I think that you have to see where the gaps are and what your interests are and really try to play a role there. Obviously, mentorship is important, but vascular is a very small group. There's about 3,500 of us in the United States. So if you have a particular talent, you'll usually rise to the top with that talent. So I think that, most of my career has been about perseverance, whether that's been in New Orleans, whether that's been with the APDVS, with the SVS. It's just kind of figuring out what is needed and trying to provide that. And usually, like I said, that's very well rewarded. There's a lot of kind of inbreeding on these committees and different societies. You'll run into the same people over and over again. And so if you're a young faculty member, even resident on the committee, you can probably provide more work to that committee than even the chair of it can. And so if you get in there and kind of work your butt off and provide things that other people hadn't thought of or don't have time to do, you'll rise very quickly. There's a real need for bright young minds in our field.
It's interesting that you mentioned Dr. Veith in that. He actually gave us very similar advice, just searching out that niche. What about resources for young vascular surgeons trying to either, make a name for themselves with the SVS or move up?
Yeah, well, the SVS is probably not a great starting point. It's our biggest society. And if I were young, while I would certainly join and engage, I think you need to look to the smaller societies like the VESC, which is really geared for younger vascular surgeons, is a great way to get yourself, known to your colleagues and get yourself some not only mentors, but people you can work with and collaborate with. SCVS is another great thing. I met a lot of the people who we started fundamentals of vascular surgery with at SCVS, just doing the Top Gun competition. And then the Program Director Society, I think, is the greatest resource. We only have about 110 programs in the country. As a young vascular surgeon, you're not a program director. But if you have an interest in education, you can ask to be an associate program director, which, there's really no limit on the number of associate program directors, an individual training program can have. And then once you have that associate role, you can actually come to the APDVS, serve on committees, and really kind of advance your career that way if academics is your goal.
And so along those lines, is there anything else exciting within vascular surgery that you think all trainees really should know about right now and incorporate in education in their training?
It's a constantly evolving field, and that's why I think if you're young and energetic, and you can pretty easy to see what's coming, what the needs are. When I started writing for Vascular Specialists, looking around, we had kind of ignored a lot of the topics that are now seem everywhere, like burnout, like the EMR situation, like just educational things, like the physician shortage. It's what you see is it's very hard to communicate through multi-institutional randomized controlled trials, because it takes years to get that data, and that's not always the most effective way of. So what I try to tell people is that look at what's going on around you and find different ways to study it. And especially in our field, I think one of the real benefits of vascular is we're constantly evolving. We're highly motivated people. We have a good balance too. We're almost 50% women now amongst our younger members, which is an advantage I think we have over radiology and cardiology, who only hold about 80 to 20% males dominate those fields. And I think that our diversity is going to really help us in the future.
So you mentioned that you're working on developing a curriculum for the fundamentals of vascular surgery. And I was just wondering if you could comment on how you're going about developing it and what your goals are and how you plan to validate it.
Obviously, we didn't invent a fundamentals curriculum. It came from FLS, and we're doing it very differently. FLS had a lot of funding, whereas this is much more of a grassroots organization, if you even want to call it an organization. So we've been testing and validating these different models since 2007. And what struck me at first when we met and decided, this was almost 10 years ago now in Houston, and John Ike ran the meeting, and we wanted to see, what were the fundamental skills that a vascular surgeon have? What was different about us rather than, an interventionalist or a surgeon? What made us unique? And as we went through these different skills, what I kept harping on were things related to dissection, the ability to dissect out a vessel, the ability to dissect out an infected graft, the ability to do an endarterectomy. This was a fundamental skill I felt that we had that was very difficult to kind of translate into a model. And so that was a crucial divergence for us. And I realized that the models we're developing are not going to be for finishing a vascular surgeon. We are not going to declare you a competent vascular surgeon after completing fundamentals, but it's literally going to be the fundamentals, the basic skills that you need to advance, because there is no appropriate model for those advanced dissection techniques other than cadavers, but cadavers are very expensive and, people can't use them every day. So I left that kind of idea behind and came up with a model where we would try to get people to have the fundamental suturing skills and some other basic open skills completed by the end of their second year, if they're an integrated program, or by, midway through your first year of your fellowship. And this way, when you went to the OR, now you can suture, now you can handle the needle, now you can cut, you can tie, you can do all these things. And so now it's kind of incumbent upon the attending to teach you more than that. If you show up in the OR and you can't suture, that's what you're going to learn how to do. You're going to suture your half of the patch. But if you come in with a mastery of that, they will happily teach you how to do the dissection or the more advanced parts of the case. So when we first started testing people, I found that half of the PGY3s would fail a basic exam, a basic open exam, which is not acceptable. Halfway through your third year, you have to know how to do an anastomosis, or you're not going to be learning a lot of the open skills that are necessary really to have an advanced open technique. So the goal is now to put this curriculum into programs and really have the residents use it on their own and study it and master the basic skills so that when they hit the operating room in their PGY 2 year, they've already got this down. And now they can go on and learn what I think are really the harder things to learn in vascular surgery, which is in the advanced dissection of complicated cases. If people see this as just a hurdle to get through, then this entire thing has been a gigantic failure. I want it to be something that residents want to do because they see the effects immediately in the OR and they see how they're treated differently because they've mastered this basic skill.
Mal, do you think there's enough buy-in that on a program level that this will have a role in certification in the future in terms of graduation?
I do think so. And so we're going through our pilot program now. And we've been very lucky. Almost every program in the country volunteered to be part of the pilot program. And we had to pick people who had, some dedicated space and resources to do this, because it's really, this is essentially a feasibility trial now. And if we get it in and it's successful, and to me, what matters is that the residents buy in. If they buy in and they say that, they did this and this helped them in the operating room, this helped them advance, then that's all I'm looking for. Then I think it will be self-fulfilling that this gets everywhere.
So, I'm going to ask then about the role for simulation. Some of the models are very low tech, but they have good fidelity. Some of the models are very high tech and sort of expensive. And where do you see the role for simulation in training?
It really depends on what you're going to do with it. If you just try to use the same models for everything, you're not going to be successful. So the high fidelity models, which are usually the endo ones, I think probably have the most use as mission rehearsal. So you'll have a complex case, a carotid stent with a difficult arch, and you can load that model in to your simulator. And I think that saves you fluoro time. It probably saves you a lot of catheter movement. And I think there's a real future there. We haven't come up, as a profession with a universal way of doing it, but I think it shows a lot of hope. And that's a big patient safety issue, is now we have less wire manipulation, less catheter manipulation, because, the mission rehearsal really shows that you can reduce the time, the floor time, everything I've said. And it does, I think, have a tremendous role in the future for difficult cases. And then the other role is to accelerate competence. So that's where the fundamentals models don't have to be very advanced. We're just trying to teach the fundamental skills, because OR time is precious. And then you have to fill in the gaps. Open cases are becoming more and more rare. But we don't want to send vascular surgeons out into the world without being able to do open cases, because that's how we differentiate ourselves from the interventionalists, is that we can do the open case. We can do everything. Simulation has a definite role there. That can be anywhere from as simple as our models, the fundamentals models, to, something with high fidelity like a cadaver. But again, you don't want to spend all your money in one place, and you have to kind of figure out exactly what you're trying to do with the simulators.
Dr. Sheahan, you just touched on the breadth of vascular surgery and the need for experience in both open and endovascular cases. In that respect, what do you see as the major challenges with education in vascular surgery right now?
Oh, we have a lot. The major challenges are, how do we refine ourselves and figure out, especially with the integrated model, which is still relatively new, what do we need from this and what don't we need? Because I tell my trainees, every rotation is essential. If I'm going to train you in 5 years to do what it took me essentially 9 years, because I'll count my lab time to do, then every single moment has to be spent learning. And so I told them, if you're on a rotation and you're not learning anything, I consider that to be an emergency, and I want to know about it right away. And as such, I've altered my curriculum every single year. And I think nationally we're seeing that as well. We had so-called 24 months of core, and now that's down to 18 months. And we're really trying to figure out what is so important to teach the vascular residents that it's more important than putting them on a vascular surgery rotation. And I think as we're getting more and more information, it turns out there's very little that is so important that we should take them off of vascular surgery rotation. So my bet is that this 24 months, which is now 18 months, will go down to 12 months of core. And we'll still have basic things like trauma and ICU. But a lot of these rotations that we had this idea of, we're going to have these well-rounded people, and they're going to rotate on radiology, they're going to rotate on cardiology, they're going to do vascular medicine. I think a lot of that time spent outside of vascular surgery was not beneficial. And I think more and more programs are coming to that realization, and we have to really fine-tune how we produce this product, because, once they finish, they're out there competing. The competition is not general surgery anymore. It's interventional radiology and cardiology. We have to have them really prepared, ready, and competent to, act in that world, in that competitive environment that they're going into.
Dr. Sheahan, that's very interesting. Do you worry at all that as you might move away from some of those so-called core things, that we might be training vascular surgeons that are no different from the other interventionalists? I mean, the old 5 and 2 program, made a surgeon physician, not just a technician.
I kind of dispute your premise there, because what I'm advocating for, and I think, it's not even an advocacy, it's just kind of a realization I've had, is that you learn to be a vascular surgeon by doing vascular surgery. And so we, as faculty, had to adjust our way of training these doctors. We used to have essentially a fully formed product come through general surgery, and then, they do 2 years of apprenticeship and a fellowship, and send them out on their way. But now it's different. Now we have to teach them a lot more. We have to teach them the core competencies. We have to teach them the value of professionalism. We have to teach them to communicate. We have to teach them how to, foster relationships with consulting doctors. But that's all, I think within our wheelhouse. I think, that's one thing that vascular surgeons are pretty good at is educating. There's not that many programs in the country. And what I found dealing with program directors is they're very interested in this type of thing. So I think that this idea that they're going to learn all these things on the general surgery rotations is false. I think that they can learn it all with us. We just have to adapt and change the way we're teaching. And I think most of the integrated programs have come to that realization and done that pretty successfully. And, what we have to, as a profession, realize is that we are not some subset of general surgery anymore. That's long since past. We're more like ENT. We're more like orthopedics. We're an entirely different specialty. We share some of the same fundamental things as general surgery, but we're not general surgeons anymore. We're interventionists. We're medical doctors. We're surgeons. We're all these things. And if we don't start learning it from day one, then, I think that's going to be a problem.
Thank you. I think you've given a great outline of the challenges and the pressures on trainees today to cover everything that's important. But then on the flip side, you've done some work with burnout. Wondering if you could give some comments on the main drivers of burnout, not only in trainees, but then also practicing vascular surgeons.
Even with a quick research into burnout, you'll see that this is nothing new. The only difference is we're calling it burnout and we're talking about it. But it's deep-seated in surgeons, and it goes back probably to the 1950s and 60s when, doctors were interested in money, title, recognition, and being these preeminent things. And they drove themselves very heavily. And, the doctors in the 30s and 40s didn't work 80-hour weeks, 90-hour weeks. That was something we kind of invented. And so we did it to ourselves. And so driving ourselves harder and harder to get money, title, and recognition led to burnout and led to divorce and led to alcoholism and suicide and all the things that we now realize, but this has been going on for 50 years. And then we've done nothing to thwart this at all. If anything, things got worse. We're constantly changing our profession with no clear plan in place. When the EHR was mandated, there was really no research done into how it affected the doctors. And it just kind of was mandated. It's in place. And now, the extra work, the extra time, that was never factored into our job. And so all of these changes that are being made in practices, a busy vascular surgeon used to do 300 to 400 cases a year. They were all open cases, and it would take a long time. But it was a completely different practice environment than I'm in right now. Now a busy vascular surgeon does 1,000 cases a year. Now the cases can be shorter, a lot more endo, but a lot more radiation exposure, a lot more different physical disabilities from wearing the lead, a lot more paperwork, right? If you used to do 2 cases a day, all paper, now you're doing 11 cases and having to start them in an EMR. It's a completely different environment, and we've done it all with no study. Nobody's looked at how it will affect us, certainly not proactively. We're now looking back and saying, oh man, this is bad news. Doctors are retiring early, committing suicide, burning out, depressed. It's just a huge epidemic that was entirely predictable, but we just are looking at it now. So we're really, really 50 years behind the 8 ball in this. Now, luckily, the SBS has taken a big commitment on and is trying to work on it, but it's going to be something much larger, something that the American College of Surgeons has to work on. And we have to kind of reevaluate the way we do every single thing we do, because it's all happened to us. We didn't choose the EMR. We didn't choose to practice the way we do. Most of the time, it's just kind of been fostered upon us without any real check on how it will affect us.
So Mal, maybe I'll ask on a more personal level. I mean, you have 3 boys and you have a wife who's got a busy clinical practice and is a vascular surgeon, you as well. So how do you guys balance the demand of family life and busy academic practices and everything else, and manage to avoid getting burnt out?
I don't know how successful I am. This is one of the great things and one of the maddening things about vascular surgery is all of our practices are extraordinarily different. We all practice in different environments with different consulting doctors, with different cities, with different, competition. and different referring doctors. Like we all have different referral patterns. We all have different, basically, disease patterns in our practice. So it's hard to say what I do can be, prescribed as a way for other people to do it. But I will say, as a husband and wife in a career, I think you have to very early on, every day, decide what your role is going to be in that day. After Katrina, when we didn't have residents, my wife and I used to scrub together. And I don't know if you have any experience with scrubbing as somebody, as a peer, and then on top of that, your wife. But it's not smooth. It's not a smooth thing. We have a hierarchy in surgery for a reason. And we kind of, I'm used to operating with a fellow. I'm used to telling people what to do. And all of a sudden, my wife's on the other end of the table, not agreeing with anything. And it's a completely frustrating experience. So we finally decided when we go in, one of us is the attending, and then the other one will assist. And so, and that kind of dictated our lives from there forward. That was 15 years ago. But every day we have roles. She'll go and do things, and I know my time to take the kids to soccer. And so if I've got a trauma or whatever, she'll come and do that. When several years ago, I asked her to kind of head up our vein practice, and she didn't want to do it. She didn't want to be labeled as the woman who does the vein. So at the last second, she kind of scrambled and grabbed all the aortic work. And she said, well, I'm going to be the vein doctor, but I'm also going to be the aortic surgeon. So she does all our fenestrated grafts. She does, every fenestrated graft she measures, she signs off on. So it's an unusual practice, but I think that what can be learned from it is that it's very important to have roles. It's very important to have understandings among your partners. And things should not just be left on set. If you're going to have call for weekends and for holidays, that should all be laid out ahead of time. It's a great source of stress not knowing what's going to happen next in your life. And I think the better you can get your culture that you work in to be one of refined roles and demonstrated roles, the more relaxed everybody will be. I tried very hard here after Katrina to set up a practice that people would want to come to, because I knew I had to build it. So I tried to lead by example. I tried to always try to work the hardest, take the most call, do the most things, be the most affable to the referring doctors, and set kind of an example and also create a fun environment that people would want to work in, that people would realize this is not, when the trauma comes in at 3 a.m., you can't be hanging your head, go, oh, woe is me. This is what we signed up for. This is going to be a great learning experience. We're all going to do it. We'll be tired tomorrow, but, we'll get some rest. We'll figure it out. This is what we signed up for, and we should all be happy to do it as much as possible.
Can you describe your experiences during Hurricane Katrina?
So during Katrina, I was at what's called University Hospital. So charity and university were basically two different structures, but they kind of shared the same training programs and essentially the same doctors. But University Hospital was kind of more in mid-city. So it was really at the epicenter of the flooding. And we had a very different experience because of how much water we got. We got initially after the storm, there was about 5 or 6 feet of water outside the hospital. But then as the levees breached, that rose to 15 feet. So we really had a very isolated situation where even the National Guard couldn't quite get to us. And we were there for about a week with no power, no water, no real anything. One of the real learning lessons I got from being there that week, we had 1,000 people in the hospital. It was a full hospital. We had an ICU, so people had to be bagged manually for days at a time. And we had no blood for transfusions. We had no medication. We could barely put IV fluids up. So it was as bad as you could possibly imagine. But we only had in that week one fatality that I think would have been avoidable in a normal hospital setting. And the reason that everything went about as well as could be expected under these circumstances was the teamwork. I was there with John Hunt, who's the chief of trauma. And what I noticed right away is the next day, we went and rounded. And we made rounds like we did every day. We brought the charts up. We made notes. And it sort of seemed ridiculous, some of the things we were doing. But we tried to carry on as much as normal as possible. Even when food was running out, we had no water. There was no bathrooms. There was, none of the things we would normally have. But we tried to make it clear that this was going to be a normal functioning hospital to the best of our abilities. And then the second thing we had people who would listen to us. We had residents. And that made a tremendous difference. I think a lot of the troubles that the private hospitals underwent in Katrina were because there were really no team. There were just groups of private practice doctors. And so when it comes to the point where, you have a 300-pound woman who is post-op day 2 from knee replacement surgery who can be rescued, but needs to be carried up 11 flights of stairs, and it's 115 degrees in that building, who's going to do it? Well, you look at your residents and then lead by example. And so we carried the woman up, and then we carried every patient essentially out of the hospital that way. And I think that without that kind of hierarchy in place, without the normalcy that we tried to instill, none of that would have happened. And things fall apart very quickly. There's this fall, when a natural disaster like that happens, there's such a strong desire to get out and see what happened to your home, to your family, to everything else, to kind of leave behind the hospital. But, I think that all of the things that we had in place as far as normalcy and hierarchy really helped us through that situation. As bad as it was, it never got to the point where we had mass casualties or, everybody got out of that hospital, within a week. And that was the thing. People are scared. They're sitting there. They're wondering, when are we going to get out? How are we going to do? And what we realized is all they wanted to hear is, we're not going to leave you. I don't know when we're getting out, but you're getting out before me. So whatever it takes, we'll get you out of here. And then once they realized that they weren't going to be left behind, then, things were much smoother. There was no panic there. And, I credit the hospital leadership and also, just the ability to have that kind of teamwork in place.
Mal, I think you're being a little modest. I had the privilege of hearing you present at Grand Rounds at Mount Sinai a couple of years ago about your experience at Katrina, and it really is amazing what you guys were able to accomplish there with such limited resources, and it was a very moving talk. So, you are originally from the Bronx, as I understand, but you're sort of an adopted son in New Orleans. And so what is it that you love about living there? What's the best thing about being in New Orleans?
Oh, it's surprisingly, all I knew from New Orleans was the ads for Girls Gone Wild at Mardi Gras and things like that. And I thought it was just going to be a crazy place, but it turns out it's very family oriented, and my kids love it. And there's just a ton to do, and it's they call it the Big Easy, and it's true. It's just so easy. After we get off the phone today, I'm taking my kids over to the zoo. The zoo is 5 minutes away from me. Everything is close by. There's great restaurants. There's great culture. And most importantly is the people. I think that the people here, while they don't always have the healthiest lifestyles, they certainly have a real appreciation for doctors. And it goes a long way. It's nice to have people who, will listen to the doctor and try their best to kind of follow the advice, but are always appreciative of, the time we have to them. And I was talking to my wife the other day, and we're very different. I'm pretty direct with people, and, my clinic, I can see 40 people in the morning, where if she sees 15 people, it'll be a miracle, and she likes to talk. And she gets out and she's like, they don't like me any more than they like you, because I spend hours talking to them, and you come in and just tell them what's up. And I said, well, all they really are looking for is that, that you care about them, and that you, appreciate the position they're in, and you just want to give them alternatives on what to do. And I find it a very different environment than I practice in other parts of the country. That I really, of all the things here, it's really the people that I think I enjoy the most.
When we were discussing this morning before the podcast, you mentioned that you were up late at night because you actually had a self-inflicted gunshot wound to the carotid. It seems like you guys deal with a lot of gun violence down in New Orleans. And so maybe we could get your thoughts on that a little bit, considering that they had the recent Stay in Your Lane controversy.
I wrote an editorial about this in Vascular Specialist a little while back. Full disclosure, it was pretty heavily edited because they don't want me writing about the NRA. But I think that, if we're going to say that vascular surgery is a separate specialty and that we are independent of general surgery, then we really have to be willing to take on issues like this. And it's very difficult. I think the American College of Surgeons has done a pretty good job with it. But we as vascular surgery, we just kind of ride on our coattails a little bit without putting ourselves in the forefront. And I think as vascular surgeons, we're dealing with this all the time. And so I do think it's kind of a waste of time to debate the NRA. I think that Stay in Our Lane controversy is just a distraction. We're science. We should debate science. We don't need to debate lobbying firms or things like that. I think, we need to look at the cold, hard facts. And, it's clear that there's a problem. And, here in New Orleans, this is something I treat all the time. I've treated people down to 2-month-olds with gunshot wounds. So, nobody can tell me that this isn't my business, by definition, my business. And so I think we need to come up with a way that we can discuss it without being emotional. We need to come up with a scientific way of figuring this out. Again, the American College has done a pretty good job. They have formed a committee on this, and they really try to remove the politics from it and the emotion, and just try to figure out, what is harmful, what is going on that can be corralled, and what are some sensible things that we can do to curtail the violence. It's pretty clear that people with a history of violence, people with a history of domestic assault, maybe shouldn't have free access to guns. Maybe there should be some limit on assault rifles and things like that. And I'm not even advocating for any of these things. I'm just saying that we need to have a discussion, and that discussion shouldn't be with a lobbying firm. It should be with each other and the public, and try to figure out where we stand on this, and advocate for the patients, which is what we do for every other disease process. And we advocate for the patients, for aneurysms, for carotid disease, for PVD. We're always advocating, but here's something that we've remained relatively silent on. I'd like to see the SBS kind of pick up this mantle and join in the conversation.
Mal, we really want to thank you again for taking the time to discuss this with us. I thought this was a great discussion and very informative.
The interviewers today were Doctors Sharif Alozi, Nicole Rich, Matt Smith, and myself, Adam Johnson. And we are Audible Bleeding, the vascular surgery podcast. You can find us on social media at Audible Bleeding or online at audiblebleeding.com.